All right, let's jump straight into this explainer and bypass the pleasantries. Today we're dissecting the clinical matrix of left middle cerebral artery, or MCA strokes. We're operating at a level here where vascular destruction dictates absolute language and highly localized neurologic deficits. If you're looking to completely master neurolocalization, this is exactly where we build the foundation.
The overarching clinical maxim you absolutely must master is this: the precise anatomical location of the stroke strictly dictates the pathognomonic physical exam findings you're going to see right at the bedside. We aren't dealing in generalities here. A blockage in a very specific vascular branch maps flawlessly to a highly predictable, immutable set of clinical signs. It completely strips away the guesswork when you're examining a patient.
Take a look at the rigid vascular territories of the brain. This anatomy forces us to draw a hard line between the superior and inferior middle cerebral artery divisions. You can see how the MCA territory spans the lateral convexity, right? But functionally, it's completely split. The superior division supplies the lateral frontal lobe, while the inferior division handles the lateral temporal lobe and parts of the parietal lobe. This anatomical bifurcation is the literal key to differentiating our aphasia phenotypes.
And here is the ultimate split screen of clinical destruction. When the superior division goes down, it yields severe motor failure and broken speech, but the patient remains painfully aware of their deficit. On the flip side, when the inferior division is occluded, it yields visual deficits and fluent nonsense, but the patient is blissfully unaware of their absolute lack of comprehension.
So, it's absolutely crucial we define these terms precisely. An expressive deficit, what we classically call Broca's aphasia, is telegraphic. It's physically frustrating. The patient knows exactly what they want to say, but they just can't mechanically produce the syntax. A receptive deficit, or Wernicke's aphasia, is the exact opposite. It features a completely uninhibited, perfectly melodic flow of words that is entirely devoid of meaning.
Module 1. The Superior Broca Matrix. Let's see exactly how a stroke strictly in the superior division of the left MCA drives this presentation. The clinical signature you'll see here is profound frustration. And why is that? Well, because the patient's comprehension remains perfectly intact. The lesion is localized to the posterior inferior frontal cortex of the dominant hemisphere. They can process every single thing you're saying to them, yet their expressive capability is totally destroyed. They speak in these 2 to 3 word choppy sentences, literally fighting for every syllable. But we definitely don't just stop at speech. Because the superior division also supplies the adjacent motor cortex and the frontal eye fields, Broca's aphasia is overwhelmingly associated with distinct physical findings. You're going to see ipsilateral or left-sided deviation of the eyes, simply because the destructive lesion prevents the eyes from looking away from the stroke. Plus, you'll see contralateral right-sided hemiparesis. And thanks to the organization of the motor homunculus on the lateral aspect of the cortex, this weakness will strictly involve the face and arm, way more severely than the leg. Moving on to Module 2, the Inferior Wernicke Matrix. Transitioning to the inferior division, we face a totally different clinical phenotype with its own distinct neurovascular rules. We're now moving out of the frontal lobe and down into the parasylvian temporal lobe. Here, the patient speaks fluently. The rhythm, the cadence, honestly, it all sounds perfectly normal until you actually listen to the content. It's a complete word salad, packed with neologisms or made-up words. Comprehension is strictly destroyed. But look at that last point. There is an absolute critical absence of any motor weakness. The primary motor cortex is spared entirely in an isolated inferior division stroke. However, you will definitely find an associated physical deficit if you look closely. Because the inferior division passes right through the temporal lobe, it provides the vascular supply to Meyer's loop, the lower optic radiations. Because of this, Wernicke's aphasia is frequently associated with a pathognomonic contralateral superior quadrantinopia. It's that classic pie-in-the-sky visual field defect right up there in the upper outer quadrant of their vision.
Module 3, the repetition barrier. Now we really need to examine the connective tissue between these matrices, a highly specific tract known as the arcuate fasciculus.
Think of this bundle of white matter fibers as the communication superhighway linking Wernicke's comprehension area in the temporal lobe to Broca's motor speech area up in the frontal lobe. Specific white matter destruction right here results in conduction aphasia. It effectively isolates a highly specific neural pathway while leaving those major cortical hubs totally intact. In conduction aphasia, both fluency and comprehension remain perfectly intact.
The patient understands you completely, and they can produce spontaneous speech flawlessly. But the absolute pathognomonic marker is a profound inability to repeat simple phrases. When you ask them to say something like no ifs, ands, or buts, it is a pure failure. The message simply cannot travel from the auditory processing center to the motor output center.
Our clinical variance box here shows exactly how these presentations diverge based solely on 3 parameters: fluency, comprehension, and repetition. Notice how repetition is impaired in all 3 of them. The true differentiation really relies on assessing fluency and comprehension. Master this matrix, and you master the clinical exam.
Now for the master case, testing the nuance. This is where we calibrate your logic for a perfect clinical score by forcing flawless integration of all this preceding data. Consider this structural blueprint. We have a 65-year-old male presenting with sudden onset odd behavior. He speaks fluently with perfect intonation, but makes 0 sense whatsoever. When you ask him to raise his arms or close his eyes, he's completely unable to follow your simple commands. This clinical profile points directly and undeniably to a receptive deficit.
You absolutely must explicitly recognize this diagnostic trap. The patient is moving all 4 extremities perfectly. There is 0 motor weakness and 0 sensory loss. The absolute absence of motor deficits aggressively tempts the untrained clinician into making an incorrect diagnosis of a psychiatric break, a drug intoxication, or delirium. But that sudden onset and the highly specific linguistic failure, they scream ischemia.
So, which of the following physical exam findings is most likely associated with this patient's condition? Under actual clinical or exam conditions, you must synthesize the vascular, neurologic, and ophthalmologic data to answer this exact prompt. You've identified the lesion, now you have to predict the collateral damage. Here's your matrix of exactly 5 highly competitive answered choices. While the top 4 options are visualized here, we're also evaluating a 5th distractor in our exhaustive choice-by-choice breakdown to lock in the correct mechanism. Let's systematically test your mastery of these clinical nuances.
Through exhaustive deduction, let's break it down. Step 1. You recognize the Wernicke's aphasia based on fluent nonsense and 0 comprehension. Step 2. You localize this strictly to an inferior division left MCA stroke. Step 3. You immediately eliminate choice A and choice B. Right-sided hemiparesis and ipsilateral eye deviation are markers of a superior division stroke or Broca's. You also toss out choice D. Impaired repetition with intact comprehension describes conduction aphasia, not Wernicke's. And regarding our 5th option, choice E, bilateral nystagmus, that's just a distractor pointing toward brainstem or cerebellar pathology. This leaves us with step 4. You strictly lock in choice C, the contralateral superior quadrantanopia, simply because the inferior MCA division supplies Meyer's loop in the temporal lobe.
To wrap up this explainer, I want to leave you with this thought. Recognizing what isn't there, like an absent motor deficit in a patient spouting fluent nonsense, is just as critical as seeing what is. Vascular anatomy does not lie. So how will you apply this absolute level of precision to your very next patient assessment?